Hi guys, hope you all are doing well. Let's start from where we left behind in the last video. We were talking in the last video in the end that how the epileptic patient will present. Like I talked before, I talk about like he will present the symptoms related to the motor, sensory or psychological. I talk about the motor one. Let's start from the sensory one today. Okay, why these three different types of presentations of the symptoms will present by the patient of the epileptic patient? It depends on which area of the brain is abnormally firing. Like say for example, this is central sulcus. Before that, this is the precentral gyrus, and after that, this is the postcentral gyrus. Okay, the precentral gyrus is that area which is actually associated with the motor functions, while the post-central is that area which is associated with the sensory functions. If the neurons in this area is abnormally firing, the patient will experience the motor symptoms abnormally. While if the neurons in this area are abnormally firing, the patient will having the symptoms of the abnormal sensation. Okay, so the abnormal sensations, and this area is actually lying in the parietal lobe. Okay, so that's why I mentioned the parietal lobe over here. Abnormal sensations refers to what? Abnormal pain, paresthesias. Okay, if the patient having an epileptic attacks due to abnormal neuronal finding in occipital lobe, patient will experience the visual hallucinations. Okay, while the temporal lobe, neurons are, if they are abnormally firing in the temporal lobe, the patient may present with the abnormal sensations and also with the psychological epilepsy, also known as temporal lobe epilepsy. It is because in the temporal lobe there is a limbic system, and the limbic system is actually associated with the different functions. They may be sensory, they may be psychological too. Okay, like the sounds, abnormal smell, emotionally, like having a burst of anger, having a hypersexual behavior, having the feelings of different, like these two terminologies also come under the heading of psychological if the temporal lobe epilepsy occurs to a patient. Okay, I just want to elaborate a little bit about it. In the temporal lobe, if we talk about the abnormal sounds and abnormal smell, sound, learn in a way that look at your face and look at your ears. Ears are actually located on the lateral side, while the nose is on the medial side. If there's some fibers, if they are abnormally firing and they are on the medial side, it means the patient will experience the abnormal smell. If the lateral fibers in the temporal lobe abnormally firing, the patient will experience the abnormal sounds. In the same way, if there is a amygdaloid body in the temporal lobe, and an amygdaloid body is actually associated with the anger and the sexual behavior. If that body is abnormally firing, the person will having the emotional symptoms like psychological. Okay, actually what happens in early life, we cannot differentiate between fantasy and reality because the temporal lobe is not developed so much. While in adulthood, we do so. We can differentiate between fantasy and reality. What happens in the temporal lobe epilepsy? These centers are actually these center like for the reality and the fantasy, they are actually their neurons abnormally fired, so that's why they present with these features. Like deja vu is what? Deja vu is a phenomena which we give when a patient presents with undue familiarity symptoms, like he's like for strangers he show the familiarity, and it's not like normal, it's psychological. Okay, so deja vu is the undue familiarity, while the Jamasu is that phenomena which we call when the patient cannot differentiate between fantasy and reality. Okay, like feelings of unreality, Jamasu. I hope so. You get clear about these two. Now let's move towards the causes. Causes of epilepsy. We divide it into two on the basis of the whether having underlying cause or not. Symptomatically, epilepsy E4 refers to the epilepsy, and the idiopathic epilepsy. What is idiopathic? It means having an unknown cause. Epileptic attacks are occurring to the patient, to the person, and having no any underlying cause. So no having any underlying structural lesions or metabolic diseases. Usually it is inherited, and the reason behind is that it's having a weak GABAergic system. As I discussed in the last video, that epileptic attacks occurs why the pathophysics behind that was whether the GABA system, which is inhibitory, is underworking, or whether the excitatory system overexcited. So that's how the epileptic attacks occur. So in idiopathic, mostly the GABAergic system is weak in the body. So that's why epileptic attacks occur and there's no any underlying lesion or metabolic cause. While symptomatic epilepsy having an underlying cause, and if we treat the cause, we can get rid of the epilepsy. I'm going to tell you about the underlying causes in detail. These all are the underlying causes, but before that, I want to teach you that you can remember easily in this way: RAP, refractory adult partial. These three are the conditions which are having the underlying cause. Say for example, a patient having an epileptic attacks, many you are giving the anti-epileptic drugs, patient is not get rid of the seizures attack, it means it is refractory to management. It means he or she having some underlying cause. That's why the epileptic attacks are not get managing by just anti-epileptic drugs. In case of the adult onset epilepsy, most of the time the adult onset epilepsy are due to underlying cause. Okay, so if we treat the cause, we can get rid of the epileptic attacks. While partial epilepsy, as I mentioned in the previous video, partial epilepsy is that one which just involving the one cerebral hemisphere of the brain. And most of the time the partial epilepsy have underlying cause, treat the cause, get rid of epileptic attacks. Now I'm going to tell you about what can be the underlying causes which can lead to the epileptic attacks. Comes towards the first, the vascular one, like some vascular causes inside the brain and causing the epileptic attacks. Say for example the stroke. Okay, I mentioned the two words in the stroke headings: the dead neurons and the not dead neurons, like compromised, and so compromised that they got died. Okay, in case of the infarction, whether due to the thrombotic cause or whether due to the embolic cause, the neurons, due to the infarction, the neurons, most of the neurons get dead, and dead neurons are not as dangerous as the non-dead neurons, as the non-dead and compromised neurons, because when they get dead, their channels, their sodium potassium channels won't work, and there are no any chances that the patient will having the epileptic. It's very less chances as compared to the in case of the cerebral vein thrombosis. Say for example the vein get thrombosed, and what will happen? Decreased oxygen supply, hypoxic condition will occur. Like the neurons are not dead, but they are compromised. Whenever there is a decreased oxygen, decreased ATP will form. When ATP is less, sodium potassium ATPase will work slowly, not work as much as as do they normally. When sodium potassium ATPase pumps not work in a normal fashion, the sodium will get accumulated in the neuron. And you should remember that whenever the sodium are the cations, whenever they get loaded into the neuron, what will happen? They are the positive charges and they lead to the depolarization of the cell. And whenever the cell get depolarized, action potential get generated and it fires. So overfiring of the neuron will occur due to the sodium accumulation, and overfiring will lead to what? Will lead to the seizures attack. Okay, so that's how this pathway is more dangerous, having more chances, ischemia having more chances to lead to the epileptic attacks as compared to the infarction, because of the dead and non-dead neurons. In case of the AV malformation, atriovenous malformation, I gave an example of the Berry aneurysm. Berry aneurysm actually occurs in the circle of Willis. These are actually the some like combination of the many vessels, and it happens, and normally they are present in the subarachnoid area. And if the Berry aneurysm occurs in this circle of Willis, it can lead to the subarachnoid hemorrhage and it can lead to the epileptic attacks. Come towards the tumors in CNS. I mentioned the three names: meningioma, glioblastoma multiforme, and neurofibromas. I want to talk about the neurofibroma. Neurofibroma is actually the genetic disorder in which the neurofibromatosis is actually the genetic disorder in which the neurofibromas, which are the tumors, form in the body. Neurofibroma having the two types, 1 and 2. 1 actually in which the whole body is involved, while the 2 is that in which the tumor just form into the CNS. And the type 2 neurofibromatosis actually leads to the epileptic attacks. Okay, remember in a way that neurofibromatosis type 1, one body, but means that one body, and type 1 is involving the whole body. Okay, in autoimmune diseases, it can be SLE, it can be paraneoplastic. So you should remember that these are the causes, If the problem is just limited to the one cerebral hemisphere, it will lead to the partial epilepsy. If it is involving the both hemispheres, it will lead to the complex epilepsy, which is generalized epilepsy. Okay, remember in that I'm just elaborating in SLE. If in SLE vasculitic lesions are just present in one cerebral hemisphere, it will lead to the partial epilepsy. But if the vasculitic lesions get extend and involve both hemispheres, it will lead to the generalized or complex epilepsy. Same here for the tumors. If the tumors are just located to one part of the one hemisphere, the patient will present with the symptoms of the partial epilepsy. If they get extend, it will lead to the symptoms of the both like generalized epilepsy. Drugs. These are the few drugs. There are many more. If their metabolites gets increased in the body, they may go to the brain and where they can cause seizures attack, like metabolites of penicillin, tricyclic antidepressants, isoniazid, cardiac antiarrhythmics, and amphetamines, which is a CNS stimulant, and etc. Come towards infections, I divide it into two, like this one and this one. Meningitis and encephalitis are just limited to the brain, while cerebral cystic sarcosis and toxoplasmosis are those infections which actually can spread to the brain from the body, from the other body parts. Okay. Say, for example, meningitis and encephalitis. These are the inflammation of the meninges, inflammation of the brain tissues, respectively. In case of cerebral abscess, means pus getting accumulated into the brain, and its main cause can be otitis media. While in cystic psychosis, what happens? It actually due to an infection, parasitic infection, and what happens? It goes into the brain, and it's actually the parasite is a tapeworm, and it goes into the brain and gets calcified there. And you should remember. A main point is that it is the only epilepsy which can be diagnosed on X-ray, because the cystic psychosis, the tapeworm, go into the brain and gets calcified. So learn in a way that CC. Okay. In toxoplasmosis is also an infection which you get acquired from the cats, and it goes into the brain and causes an epileptic attacks. Come towards the metabolic. In metabolic, there are the three conditions: hypocalcemia, hyponatremia, and hypoglycemia. I'm going to elaborate these three features, how they can lead to the seizures attack. Okay, hypocalcemia, how it can lead to. I just elaborated here that it is a sodium channel, and these are the calcium. Okay, the calcium are actually a guarder of the sodium channels. Normally, the calcium are the guarded in a way that negative regulate the sodium channels to some extent, not allow it to do overwork. Okay, the sodium does it works in a limited way whenever the guarders are present. If the guarders are not there, the sodium will do overwork. When the sodium will do overwork, what will happen? More and more sodium will move into the cell, cationic clotting will happen in the same way, and overfiring of the neurons will happen. These 3 points get fixed into it if the calcium is low. While in case of the sodium, if there is a hyponatremia, it means low sodium into the extracellular fluid. You should remember, where the sodium goes, water goes behind your sodium. If the sodium is less in the extracellular fluid, what will happen next? Means that then the water will move from the extracellular fluid. Where it will then go? The water will go where the sodium is. Sodium is not there in the extracellular fluid. Whatever the sodium is present inside the cell, the water will move behind that. Okay, so whenever the water moves into the cell, what will happen? The neuron will get swelled, and swollen neurons have more chances to get an epileptic attacks. Clear? Makes sense? I hope so. What is in case of the hypoglycemia? Hypoglycemia, low glucose, less ATP formation. Its path is also same. Less glucose, low ATP formation. Sodium potassium ATP pump won't work. Sodium accumulate into the neuron because the pump is not working. Pump function is that to move the sodium out of the cell and to get the potassium into the cell. If the pump is not working, it means the sodium will accumulate into the neuron, and cationic clotting will happen, overfiring of the neurons, and whenever the neurons are fired, they will present in the seizures attack in the form of seizures. Come towards the renal failure. Acute renal failure, chronic renal failure, both can lead to the seizures attack. In acute, what happens? Increased potassium can lead to the seizures attacks, while in chronic renal failure means kidneys are failed chronically for a long time. It means waste products are being accumulating in the body, and when waste products are being accumulated in the body, they can go to the CNS and can disrupt the multiple neurons and can lead to the seizures attack. I hope so. It makes sense. Until next time. Bye bye.